Hi, and welcome to this recorded presentation on the Minnesota Stroke Registry and Portal Updates. My name is Ali Fuji. I'm the Stroke Quality Improvement Coordinator here at the Minnesota Department of Health. Our agenda for this recording is we'll go over some updates and do a little refresher of portal tips. Then we'll go over chart audit results for 2019 and go over a little bit of what's happening for the 2020 chart audits that are wrapping up. And then after that, we'll review some exciting portal updates that include updated questions and enhanced skip logic that you all have been waiting for. If you're in a hurry, feel free to fast forward to the section on just portal changes, which is towards the end of the presentation. So what I've been up to, it's been a while since I've hosted a webinar, so I just want to let you know what I've been up to lately. I've been pretty quiet. As most of you know, I was on COVID-19 duty for part of last year, then gone on maternity leave at the end of summer and most of the fall. I had a healthy baby girl named Lucy. I came back in November and was quickly reassigned back to COVID-19 responsibilities before I had even had a chance to catch up on everything I'd missed. And then at the beginning of the year, we were busy working on our application for CDC's Paul Coverdell Acute Stroke Program, as many of you might know, as we were asking for letters of support. But I'm happy to be able to concentrate on the registry and portal again and work with all of you. Moving on to MDH Program Updates. Just a reminder, we have now resumed normal scheduling for our data submission deadlines. So Q4 of 2020 was due May 15th. So all of the 2020 stroke cases for your hospital should have been submitted by now. If you haven't been able to keep up with the deadlines and are behind, please email me and just let me know. We're doing data checks and it's a lot easier if you just tell us about it. Another update is our Quality Improvement Awards application deadline was June 30th, but now we've extended the deadline to Friday, July 30th. And you can email me with any questions you have about the application process. And lastly, we're excited to announce that we have had our BFAST stroke awareness materials translated into Spanish, Somali, and Hmong. This is our Every Second Counts campaign. And you'll be able to download them as you have the English versions. So we'll offer the graphic file for your customization as well, if your hospital wants to do that. We have one medication update, and that's the list of approved cholesterol-reducing medications has been expanded. 2 PCSK9 inhibitors were added, Nexletol and inclisiran. So I just want to go over some quick portal tips. Since it's been a while since my last webinar, I want to do a quick refresher on what you can find on the Resources tab. I also wanted to do a reminder on how to update your email address in the portal. When you come to the homepage of the Minnesota Stroke portal, even before logging in, you can access the Resources tab in the top right corner. When you click on it, you'll see 4 options appear. The first one at the top is the Minnesota Stroke Registry Abstraction Manual. That's a mouthful. This is where you can find the reporting deadlines and the cholesterol reducing medication list I just referenced earlier. Now, for those of you new to abstracting or new to participating in the Minnesota Stroke Registry, the Abstraction Manual is designed to give you a detailed overview of all things related to the registry, like case definition, the required elements, reporting deadlines, and like chart audit information. It also discusses what is done with your data you enter, including our own MDH reporting and the reports you can pull on your own facility from the portal. This manual, I think, is applicable to longtime users of the registry that need a refresher or a quick reference, as well as those who are new to their position. Next up is the Minnesota Stroke Registry Data Dictionary, and this is probably the most used resource for the registry as it explains what each element is that we want to collect and how to enter it into the registry correctly. You have the ability to click on each of the elements in the table of contents and it will take you to that exact spot in the data dictionary. It's organized by portal tab, so it should be easy for you to find what you're looking for. You can also do a search and type in exactly what you're looking for as well. I'm constantly updating this document so it's helpful, current, and as clear as possible. The data dictionary is also what our chart auditors use to see if you've abstracted a case correctly. So I just want to stress the importance of this document. If you have any questions about it, about the guidance in it, as always, just email me and we can go over how to best answer your question. Something that might be helpful for those of you new to using the Minnesota Stroke Portal is looking at the Minnesota Stroke Portal navigation guide, because it has the basics of how to get around the portal and instructions on how to do the most common activities like enter cases, run reports, and apply for designation. Lastly, we have the Minnesota Stroke Portal YouTube tutorials. And these are for users that like to hear and see and maybe use the navigation guide to follow along in the video. But I created these recordings myself doing the most common activities you would do in the portal, like logging for the first time, entering an ED department only patient, because it's different than when you enter an admitted patient, submitting a designation application, and how to run reports. They're also available on our stroke program YouTube folder on the MDH's YouTube channel, along with all of our recorded webinars. So recently I've seen more email changes on our stroke contact list, and as more hospitals change their name or join other systems, I want to be sure that your email address to access the portal is up to date. If it's not, you may experience issues if you need to reset your password. So to update your email is really quite quick. In the top right-hand corner of the portal screen when you log in, you should see your username. And if you click on your username and click on user profile, it will take you to a screen to update your email, as you can see in the middle picture. After you click save, at the top menu bar, you'll see options to go back to the portal or sign out, and that's it. That's all you need to do to update your email address. If you have any problems updating it, just let me know and we'll try to figure it out. Next, we're going to review some information on chart audits. We'll look at the results from last year's chart audit of 2019, and then we'll look ahead to the 2020 chart audit that's currently being wrapped up right now. So last year we performed the chart audit on 2019 records. I haven't had a chance to report back to you on the results for a variety of reasons, but COVID-19 reassignment and being on maternity leave as well as returning to work during a pandemic turns out to be challenging. So here we are now auditing 2020 charts and just now reviewing 2019. This isn't ideal, nor is this how things would normally be reported back, but here we are. So we identified 298 medical record cases from 2019 for APRA to re-abstract. In the end, they received 288. 10 records were either not received or end up being the wrong healthcare encounter. The CDC requests 66 data elements to be re-abstracted from each case. The number of data elements actually re-abstracted from each case will vary for a variety of reasons, but whether the case was admitted or not, administered alteplase or not, that will change the amount of re-abstracted elements. In the end, 10,402 elements were reviewed with 345 discrepancies found. So discrepancies can mean a few different things, such as the information given to APRA did not match what was abstracted into the registry, incomplete chart records provided to APRA caused the discrepancy, so like missing information, or the element abstracted did not sufficiently meet the criteria in the data dictionary, or the information that was recorded as not documented actually was documented and found by APRA upon re-abstraction. So after everything was said and done, we ended up with a correlation rate of 97%, 1 percentage point higher than the previous year, which is really great. So although we had a strong correlation rate, or a very strong correlation rate of 97%, we had an even lower correlation percentage in stroke education. So I just wanted to look a little bit closer at this. When we investigated stroke education, we found that many of the same issues that have been problems in the past were problems this year as well. One being incomplete records sent to apiary that did not include discharge information. So if your hospital has the detailed stroke education in the discharge information and that's not provided to apiary, that would be a discrepancy, right? Because they didn't have that, didn't look like you gave it to them. So then to apiary, that's a discrepancy, even if you may have given it to them. That's why it's important to provide them the whole medical record and work with your abstractor to make sure that everything that they're drawing from is included to apiary in that medical record. Also, statements like stroke binder given, stroke education given do not meet the criteria outlined in the data dictionary that says what you need to have given or written to the patient to give you credit for saying stroke education yes or no. Another aspect is that during this particular group of chart audits, only about 20% of the records admitted patients, so it led to a smaller N or denominator. And so each discrepancy had like a greater impact at the overall correlation rate. Those are just some things that impacted stroke education last year. As for documented contraindications to statin as a reason for not prescribing, as you can see that is included at the top of this chart, this only applied to 15 medical records and only 3 discrepancies were found. And since this has not been an issue in the past, we're not too concerned about it, but we'll just keep monitoring it. Because stroke education continues to be one of our more challenging elements, I've collected some tips from hospitals that have developed systems for documenting stroke education so the abstractor can easily locate this information to abstract accurately. The key word here being accurately. I just want to note that we aren't looking at the STKA stroke education performance measure to see if it was done. Chart audits look to see if it was abstracted correctly. For example, this means that if a chart did not show stroke education on how to activate EMS, we're making sure that the abstractor selected no for that element. If they had selected yes and the information wasn't there in the medical record, that would have been a discrepancy. Now, moving into stroke education tips. One, top reason, they must be written instructions or educational materials that specifically say activate EMS, stroke risk factors, etc. Were received or accepted by the patient or caregiver. For risk factors, they must be mentioned in the context of risk factor for stroke and patient specific. Just saying change your diet or lower your blood pressure will not be sufficient. For example, if a patient has high blood pressure is a risk factor for stroke. Information on high blood pressure. Some hospitals have added dot phrases or quick text to their EHR so it can quickly add the education to the after visit summary. Some of the options will have all the stroke risk factors listed and the nurse would edit to what only applies to the patient. That way the patient knows exactly what their risk factors for stroke are and the abstractor knows where to look to check if it was done. So it's a win-win. Make sure the education you are giving the patient or caregiver is documented in the chart and included to apiary. If your detailed education is given in the after visit summary, make sure that's sent to apiary. If you notice that stroke education has been difficult for your hospital when you view the individual report given, we strongly encourage abstractors and stroke coordinators to work together on solutions to remedy this. It could be a great quality improvement opportunity for your hospital and stroke program. So I'm just going to briefly discuss the 2020 chart audit. We partnered with Apiary Consulting once again, and all of you by now will have worked with them. Their names are Mike Selvage and Andrea Frazier. They're currently wrapping up the project now, and all participating hospitals should be receiving their individual reports soon. I'm going to spare you my usual rant on chart audits and why they're important, and just review some of the basics. Same as other years, about 6 to 8 hospitals will be audited. Since we have audited every hospital in the last 2 years. We did a new mix, which meant that some hospitals got audited 2 years in a row and some didn't. While it'd be ideal to look at each hospital every year, we do not have the resources to do that at the moment. So it's just will continue to be a mix. CDC had us look at the same 66 elements we did last year. No changes from other years, and preliminary results suggest similar trends as other ones, such as stroke education continues to be our biggest area of improvement. The next bulk of the slides will be on the changes that are happening in the portal. This includes updated elements, new questions, and enhanced functionality. First up, I'm going to go through the data element changes tab by tab, organized by the portal tabs. So first up is the evaluation tab. Patient setting where stroke symptoms were discovered has been updated, and there will also be a new question appearing on this tab asking about active bacterial or viral infection. So you may have noticed that this question has already been updated in the portal a little while ago. It was changed while I was on maternity leave without me knowing. Surprise! This question used to just be, did stroke occur after hospital arrival, ED observation inpatient? And the primary purpose was to indicate whether this was an inpatient stroke. This question is still determining whether it was an inpatient stroke or not, just gathering a little more information. So if you mark yes, stroke occurred after hospital arrival, this case will still be excluded from most reports. If you have any questions on how to answer this element, definitely use the data dictionary, which talks about each facility and when to select it. And also, if you're wondering about whether or not it's excluded from a report, use the registry manual, abstraction manual that I talked about earlier. That has all of the reporting specifications outlined in it. I just want to do some quick practice with a patient scenario. What I'll do is read the scenario and you can press pause, think about how to enter it into the registry, and then press play again, and I'll go over the answers. So nursing home resident started experiencing left-sided facial droop during doctor's appointment in clinic. This clinic is connected to a hospital, transferred to the hospital's ER and assessed for stroke. How would you enter this into the registry? So here's where you press pause. I'm just going to go ahead and go to the next slide for the answer. We would select outpatient healthcare setting. The patient was in a clinic, an outpatient setting, even though it's connected to a hospital. Patient was at a clinic visit, not in hospital or nursing home. So that's why we would select outpatient healthcare setting. Now let's move on to new questions you'll see on the evaluation tab. So the CDC would like us to start collecting information on COVID-19, and we want to know whether there is documentation that the patient had an active bacterial or viral infection at arrival or was diagnosed with one during this episode of care. So select one of the allowable values when a confirmed diagnosis is documented by a provider or when a positive test result is documented in the patient's medical record. For emerging infectious disease, we have listed some examples in parentheses to help distinguish what we might mean by emerging infectious disease. The big thing to remember here, which is key, do not select if the documentation states only suspected, probable, possible, or inconclusive infection. We always want confirmed. And as always, select none or not documented when none of them apply to the case. Let's keep in mind that this is a new question, so please email me with specific questions should they arise if the guidance isn't clear, because this is still an evolving element. Now, if you find a confirmed infection of an emerging infectious disease, a follow-up question will appear to specify which emerging infectious disease they were confirmed to have while at your hospital. So select what the patient was confirmed to have. For COVID-19, an infection is considered active if they have tested positive within 10 days of coming into your hospital for the stroke event or if they were diagnosed with COVID-19 at your hospital or during their hospitalization. So at the moment, we don't have a ton of guidance under what would fall under other emerging infectious disease. And I don't know about you, but I don't care to find out anytime soon. But that's what I wanted to know about other emerging infectious disease. So let's do another patient scenario. Like the previous one that I did, I'm just going to read this and then move on to the next slide with the answer. But for you, feel free to press pause and think about how you would answer this and enter it into the registry. So a patient arrives at hospital at 0800 with arm weakness on right side and difficulty speaking. They are administered alteplase and then transferred to a primary stroke center. In the patient's record, you see a positive COVID-19 test result from 3 months ago. How would you enter this patient into the registry? Since it was not within 10 days of hospital arrival or during that episode of care, we would select none or not documented. It was not considered an active infection at the time they came into the hospital. All right, so next up is the treatment tab. The first item up is if you select yes, that IV thrombolytic therapy was initiated at your facility, you will now be asked to specify the IV thrombolytic used, so either alteplase or tenecteplase. As tenecteplase utilization has grown, we want to capture which type of thrombolytic therapy the patient received. You'll notice that questions that ask specifically about alteplase now have been changed to IV thrombolytic in order to capture tenecteplase as well. And then also there's a new medical reason for IV thrombolytic delay greater than 45 minutes or 60 minutes, and that is the need for additional personal protective equipment. All right, so starting with if you select yes, was IV thrombolytic initiated at this hospital? You'll be asked the usual questions like date and time of initiation, but now you'll also be asked which IV thrombolytic was used, alteplase or tenecteplase. Please note whether alteplase or tenecteplase was administered, both are going to be included in your door-to-needle metrics. If your facility administered alteplase to the patient, select alteplase. A box to collect total alteplase dose will appear. It's optional. You do not have to answer it, but just please note that the total dose for alteplase is the bolus and infusion in milligrams. So if you select tenecteplase, it will ask total dose given in milligrams, and that's the total bolus. This question is optional. And another question will appear, which is reason for selecting tenecteplase instead of alteplase. Now, this question is required, and if the answer is a large vessel occlusion with potential thrombectomy or mild stroke, select those. It should be documented by a physician, advanced practice nurse, or physician's assistant or pharmacist as the reason why tenecteplase was chosen instead of alteplase. Now, if large vessel occlusion with potential thrombectomy or mild stroke are not the documented reasons why tenecteplase was chosen over alteplase, or no reason is documented in the medical record, then choose other. If there is a specific reason noted in the medical record, you should type it in the text field that appears when you select other. For example, when this is a system standard of care, we would accept this as the reason. So go ahead and type that in there. If IV thrombolytic, this includes alteplase or tenecteplase, was initiated greater than 45 minutes, you are always asked if eligibility or medical reasons were documented as the cause for delay. So a new medical reason that is acceptable for delay is when there is documentation in the patient record that treatment was delayed so that the healthcare providers could obtain additional personal protective equipment, or PPE, because the patient had confirmed or suspected infection. If this applies to your case, you can select yes for eligibility or medical reasons documented as cause for delay, and select yes that it was because the need for additional personal protective equipment. Normally, we don't ask the specific medical or eligibility reason. You just refer to the data dictionary to see if the documented reason qualifies. However, CDC would like us to collect this one in particular if the delay was due to need for additional personal protective equipment. So let's go over a patient scenario for this. Again, pause to think. I'm just going to move ahead to the next slide. So patient arrived in ED at 11:20, experiencing stroke-like symptoms as well as a cough and fever. COVID-19 test was performed upon arrival. Alteplase initiated at 12:30. How would you enter this patient into the registry? So for this one, we would answer no. There were no eligibility or medical reasons as a cause for delay. There's no documentation that additional PPE was the cause for delay. If there was documentation that a suspected COVID-19 infection caused the delay, such as COVID-19 test and additional PPE prior to alteplase initiation required, if you only have documentation of a COVID-19 test, this would not be sufficient. Just like other eligibility and medical reasons as a cause for delay, they must be mentioned in the context of IV thrombolytics. If you have any questions about this, definitely go to the data dictionary or email me. The next edition is on the History tab. Now you'll see a new option for History of Emerging Infectious Disease. The emerging infections of interest are SARS, COVID-19, and MERS. So if the patient's known medical history includes any of those SARS, COVID-19, MERS, those in the parentheses, select the history of emerging infectious disease. And once you select that option, more checkboxes will appear to collect which emerging infectious disease the patient had. Select all that apply to this patient, but please note this does not include current infection. I repeat, this does not include current infection. So let's go back to that case example we looked at earlier when we were talking about active infection. So remember, the patient arrived at the hospital at 1800 with arm weakness on right side and difficulty speaking. They are administered alteplase and then transferred to a primary stroke center. In the patient's record, you see a positive COVID-19 test result from 3 months ago. How would you enter this patient into the registry? Again, pause here if you need a moment. We would select none for active infection and then record history of emerging infectious disease in the medical history and select SARS-CoV-2. Let's just do one more for good practice. So the patient was treated for stroke and admitted to your hospital. Patient developed a fever and a cough during their stay and later tested positive for COVID-19 before they were discharged. While abstracting, you also see they had a positive COVID-19 test a few months ago. How would you enter this case into the registry? So now for active bacterial or viral infection at arrival or during this episode of care, you would select emerging infectious disease and select COVID-19 because they tested positive during this hospital stay. Under known medical history, you would select history of emerging infectious disease and select COVID-19 because there is record of this patient testing positive a few months ago. If you have any questions, again, consult the data dictionary or shoot me an email. Next, I'm going to review the new enhanced functionality that has been added to the registry. So most of the changes you'll see are on the inpatient tab and one is on the treatment tab. We all know the inpatient tab is on the longer side and can feel even longer when you see questions that do not apply to the case you're entering because they were either comfort measures only or discharge to hospice, for example. So I hope this helps. The first skip logic is on the treatment tab, and if the patient arrives more than 120 minutes from last known well, you will no longer be asked the reason for not administering thrombolytics in the 0 to 3 hour window. If you select comfort measures only, day 0 or day 1, the following questions will no longer be visible on the inpatient tab. For patients who are comfort measures only day 0 or day 1, they're excluded from these measures, so we don't need to collect them. So we have 12 questions less. That means you only have 7 questions to answer on the inpatient tab. And so those are STK1, VT prophylaxis, STK2, discharge on antithrombotic therapy, STK3, anticoagulation therapy for atrial fibrillation, STK5, antithrombotic therapy by end of hospital day 2, STK6, discharge on statin medication, STK8, stroke education, STK9, history of smoking, STK10, assess for rehabilitation. Now, if you select comfort measures only day 2 or after, or timing unclear, the following questions will no longer be visible on the inpatient tab. And those are 10 questions less, so you'll only have 9 questions left to answer. So the questions that will appear anymore are STK2, discharge on antithrombotic therapy, STK3, anticoagulation therapy for atrial fibrillation, STK6, discharge on statin medication, STK8, stroke education, which is 5 questions, STK9, history of smoking, and STK10, assess for rehabilitation. So what does this look like? So I want to let you know how it looks in the portal. So here's an example of when you see comfort measures only is not determined or not applicable to your stroke case. If you admitted this patient, you'll see 19 questions are required to fill out on the inpatient tab. So now here's what it'll look like if you admitted a patient and they were determined to be comfort measures only day of or day after arrival. The number of questions on the inpatient tab is reduced from 19 to 7. You just need to hit save on the evaluation tab in order to apply the skip logic. Now here's what it will look like if you admitted a patient and they were determined to be comfort measures only day 2 or after. You'll see the number of questions will go down from 19 to 9. The last skip logic item uses discharge disposition to determine how many questions on the inpatient tab you'll need to answer. So if you select hospice home, hospice healthcare facility, acute care facility, expired, or left against medical advice, the following questions will no longer appear on the inpatient tab. And so much like comfort measures only day 2 or after, you'll have 10 less questions to answer on the inpatient tab. So in the end, you'll only have to fill out 9 questions on that inpatient tab. And so the questions that will no longer appear are STK2, discharge on antithrombotic therapy, STK3, anticoagulation therapy for atrial fibrillation, STK6, discharge on statin medication, STK8, stroke education, again, that's 5 questions itself, STK9, history of smoking, and STK10, assess for rehabilitation. And that's all for now. Please email me with any questions regarding this presentation or anything about the registry or portal. If you have questions about elements, in particular the new ones, definitely check out the data dictionary. I have updated that and the abstraction manual with these changes. Now, as always, if you have a sticky or tricky case, I should say, feel free to email me and we can talk it through how to answer questions. I hope you all like the new enhanced functionality and skip logic placed in the portal. We worked really hard to get that to you. A lot of you have requested that change. Please continue to share feedback with me. We may be slow in our ability to respond, but we still take note and we try to get it done as soon as possible. So thank you again and have a great day.